So these are my disclosures. So we know that the European guidelines have recommended LA closure for patients with contraindication and for oral anticoagulation and high risk of thromboemboli. But the truth is that the LA closure trials, randomized controlled trials, have been performed in patients with no contraindication to oral anticoagulation, and after the closure, these patients were treated with oral anticoagulation. But the real life is that we're treating most of the patients with contraindication to oral anticoagulation, and with no evidence, we decided to start in treating them with oral or single oral or double oral antiplatelet therapy. And therefore, we have two kind of subset of patients, and we have two kind of subset of populations, and therefore, the post-procedural medication is still unclear, and we still don't know how we need to follow up these patients. So let's start from the beginning. I think it's a good question if we try to check why the clots get into the appendage, so we understand what we get once we put a device there and what we change, and if this makes any change also in the medication that these patients need to receive. So we know that the appendage is a cul-de-sac, and we know that when the appendage is no chicken wing shape, or there is an increased volume, or there is a small osteal size, or it's a short length appendage, we know that there is more clotting there. And also in patients that they have a clear LA dysfunction, that we know that the clots get there more easily. But we have to remember that we have the visual triad on these patients, and it's not only this cul-de-sac, it's not only this abnormal blood stasis which makes these patients getting clots there. We have to understand that there are some pathological studies that have shown that patients in atrial fibrillation have a change in the endocardial, there is damage there is kind of a rough endocardium, so this makes also this patient get clot. And also there is an abnormal hemostasis, systemic hemostasis changes that we will favor the clotting on these patients. So if we put a device there, but probably will fix the first condition immediately, and it won't happen that with endocardium because we will switch the endocardium with a nitinol layer, so it is still something there that might get clot. And mainly what we won't fix is the systemic hypercoagulability status of these patients. So from this point of view, we would favor probably oral anticoagulation after LA closure on these patients. But let's go to the other side. What happens with the devices on these patients? So if you check how these devices heal, we know from animal studies that the first thing that these devices do is there is an absorption of plasma proteins, and the fibrinogen gets into contact with the platelets, and there is a platelet adhesion, activation, and aggregation. So from the device point of view, probably we will favor the dual antiplatelet or single antiplatelet therapy. So we get into kind of HAMLET dilemma because we need to choose if we are more concerned about getting clots in the device or we are more concerned of getting bleed on our patients. And mainly, the main question is, do we need to anticoagulate these patients, anti-aggregate, or both of them? So this is a quick picture just to know which is our medical armamentarium nowadays to treat those patients after closure. And I won't go into detail, just remember that the antiplatelet therapy has the limitation that the offset of action is pretty large. But the good thing is that you can reverse them with platelet concentrate quite fastly. And in the other side, from anticoagulants, the advantage is the offset of action is much shorter. The disadvantage is that the new oral anticoagulants, there haven't still available antidotes on the market. And for the warfarin, it takes a bit longer than for this antiplatelet therapy. So probably in this group of anticoagulant treatment, the low molecular heparin will be a really interesting molecule in terms that it has a short life, and we can reverse it immediately with protamine. So here comes my first question. I mean, we know a little how the device, what we get with the closure, how the device heals, and which are the therapies that we have. So how do you treat your patients after LA closure? Do you use the novel oral anticoagulants? Do you use dual antiplatelet, aspirin alone, or warfarin? Okay, so if we go to the international registry published by THROMBUS, you can see that this is kind of a bubble tower effect. I mean, if you check the treatments that were used in this registry, there are almost more than 12 options that were used. However, it's true that almost half of the patients were treated with single or dual antiplatelet therapy. So since most of you have answered that you will use antiplatelet therapy, the next question is why? Because there is a lower bleeding rate than oral anticoagulation, because there is a lower device thrombus rate, or because there is a better adherence of the patient, or all of them. We could expect this one. No? And there is kind of many different kind of answers. But the truth is that we've been here. I mean, this is kind of the Sisyphus stone story, because we already have some evidence about the antiplatelet and the antithrombotic therapy. We have to go back to the active trials. In the active W, they compare anticoagulation or anticoagulation to double antiplatelet therapy among patients with atrial fibrillation, and they showed that there was a clearer reduction of a stroke with oral anticoagulation. Indeed, the study had to finish early, and there was no difference in major bleeding comparing dual antiplatelet therapy to oral anticoagulation. Moreover, if you go to the active trial, they compare also the single antiplatelet therapy to the double antiplatelet therapy, and they showed that there was a slight reduction in a stroke in the patients with dual antiplatelet therapy, but there was an increase of bleeding on these patients. So why are we choosing antiplatelet therapy? So maybe we can get, indeed in the guidelines themselves, in the atrial fibrillation guidelines themselves, they also suggest that don't switch from oral anticoagulation to dual antiplatelet therapy because of bleeding, because the bleeding rates, they are equivalent in both groups. But why were we using so oftenly an antiplatelet therapy? So maybe the answer comes from this study. This was recently published. It's a registry in an emergency room of patients that come with bleeding due to antithrombotic therapy. So this is what happens to these patients. As you can see, most of the patients come from bleeding because of GI bleeding or intracranial bleeding, and what we see is that patients with intracranial bleeding, they have a higher rate of mortality compared to those with GI bleeding. Indeed, if we check the therapies they were receiving, most of the patients that were receiving antiplatelet therapy, 80% of them, they were just on single antiplatelet therapy. So we've compared to oral anticoagulation, what we see is that in the oral anticoagulation patients, there is a wider range of different type of bleedings, but in the antiplatelet therapy, most of them, they get only GI or intracranial bleeding. The truth is, the rate of intracranial bleeding is almost similar in the two groups, in the anticoagulation and in the antiplatelet therapy group. But what they found out is that the patients that were on oral anticoagulation, they have an increased rate of mortality compared to patients on antiplatelet therapy. So let's stop here and let's go to the other side. Let's go to the thrombus side. So the truth is that we've been there also. I mean, we've been closing ASD and PFOs for a long time. We've been using different also strategies, pharmacotherapy therapies. And the truth is that the device thrombosis is mean almost, there's a range almost comparable than that we are having nowadays with ACP. So, and the truth is that we didn't get a clear answer from these trials and these registries neither. So where are we now? We have this background, and where are we now? So if we go to the randomized trials, and we have learned that with the oral anticoagulation, dual antiplatelet, and continuing with aspirin, what we got is kind of similar results in different trials with a low rate of stroke and thrombosis of devices, and with a bleeding rate almost close to 5%. The good thing of this study is the strength that it's a randomized trial, and as you know, the quality of data is really good. There is a really good follow-up of the patients, so probably all the events have been well detected, and the rates that they're describing, they are really reliable. The problem is that, as we said in the beginning, these are not the patients that we are treating nowadays. I mean, think that three-fourths of the patients that we are treating, they are patients with contraindication to oral anticoagulation that won't be included in this study. If we go what we call to real life, I have included just those registries that have used routinely dual antiplatelet therapy. So what we see is that, in almost all of these series, the hospital was pretty high, so the risk of bleeding of these patients was really high, but there was a great variability on the results in terms of stroke and bleeding. So the problem of these registries and the weakness is that there is a huge variability, as I said, and the reliability of the data that also we can put it into question because most of them, they were retrospective registries. So it's difficult to know the real rate of device thrombosis that might be important. So with all that, which is the consideration we can do about the antithrombotic therapy on these patients? So probably the patients that they don't have any contraindication to oral anticoagulation and we are closing the appendage, we could standardize the treatments if there are randomized studies. If we go to the patients with contraindication with oral anticoagulation, to the bleeders, probably we need to take into account where they're bleeding from. And in any case, we should consider that it's important first that checking the HAS-bleed, not to decide the kind of therapy, but probably we can correct some of these factors to reduce the bleeding first. And the second thing, it's also important, check the adherence of the patient to the therapy. Obviously, everything that is single pill, single shot will be much more easier than if they have to take more than one pill. So this is kind of a homemade algorithm to decide the treatment of this patient. So as I say, with patients with no contraindication to oral anticoagulation, we should probably follow the Proctet AF and algorithm because we know it works. We also can take advantage to those patients that they are already in some kind of treatment, for example, patients that receive PCI and they're on double antiplatelet therapy. If they tolerate it well, we should keep it. It's going to be easier for them. And also if they have already a medical therapy like new oral anticoagulation that they've been tolerating well, probably we should continue with that after closure. What happens with the bleeders? I mean, if we go to the bleeders, we go back to the bubble tower. I mean, if we have to consider all these variables, we have different options. But just to make it simple, I think it's good if we have some thoughts about that. I mean, just avoid oral anticoagulation in patients with intracranial bleeding, external or muscular bleeding, because it's shown that the rate of this kind of bleeding is higher, and in case of external muscular is higher in oral anticoagulation, and the mortality looks to be higher in intracranial bleeding. Avoid single and dual antiplatelet therapy on patients that had GI bleeding. And in case that you have any doubt and there are real bleeders with really high HAS-bleed and you want to have a good control of the antithrombotic therapy, we should consider low-weight molecular heparin in terms that they have a short life and you can reverse it quickly with protamine. So this is what we do with the therapy, but it goes together with the imaging in terms that and it makes sense that whenever you have an event during the follow-up, we should imagine it with TE. In any time that you want to change the medical therapy, it makes sense to do a control to see that everything is looking good. And obviously, it makes sense also after the procedure, immediately at 24 hours, you check that there is no pericardial effusion and the device is in place. So depending that what you want to do, you can use a different technique. But let me first put you my last question. So what do you do in your center for the following up? Do you do a regular TOE at 1 month, 3 months, 6 months, or you don't just follow them up? Okay, I think this is a problem. We have still the bubble tower here, and probably you should. My feeling is that you should do the imaging at the point that you decide to change your medical therapy, and after that you have to decide what you look for. So if you just want to check the device and pericardial effusion, transthoracic echo is good enough. You know that you have in the transthoracic echo you have the 8 sign. It means that the device is in place. It's in the right position. It's a quick way to check it. If you have a device thrombus, obviously, TOE is still the gold standard, despite you can even see it with a CT scan. But as I said, TOE is gold standard. Here you can see a thrombus at 3 months follow-up on the patient. For the peri-device leak, and I think TOE and CT, they are really good devices to check it. And as we've been saying in all this session, and probably and after, Dr. Tsikas will talk about that. And they've been trying to banalize this and try to show that it's kind of a benign, independently in the size of the leak. But there are already some case reports where with large leaks where they got clot there, so it's something that we should be aware of. And finally, we should take a glance to the future. I think the key here is to have the imaging modality that will show us the healing of the device and the endothelialization, because at this point, once you see that this is completely healed, probably this will allow us to stop any blood thinner. So in conclusion, and we need still probably randomized controlled trials to decide which is the medical therapy, the optimal medical therapy on this patient after LA closure. Remember that patients with no contraindication to oral anticoagulation, almost 25%, we should consider the PROTECT AF protocol because it's already there and it's shown to be effective. In patients with contraindication to oral anticoagulation, we might check which kind of bleeding they have to decide the best antithrombotic therapy. And we should use imaging just immediately before discharge to see that everything looks good. Just when we have clinical evidence, it makes sense to do it. And just change when we have a change or a stopping of the medical therapy. So finally, I just want to tell you that once in a while you have kind of complex case and you are pretty happy with the result. And after the closure, you want to celebrate the victory like this shocky. But you have to remember that this doesn't finish here. This doesn't finish with the device. This finishes when you take all the medication to this patient. So if you don't have it into your mind, maybe you can lose the race. So thank you very much.